So at this time, I'd like to introduce our first speaker for neurology. Dr. Melody Ryan received her PharmD and Master's of Public Health degrees from the University of Kentucky. She completed a pharmacy practice residency at Duke University and a neuroscience fellowship at the University of Kentucky. She holds appointments as Associate Professor in the College of Pharmacy, Division of Pharmacy Practice and Science, and at the College of Medicine, Department of Neurology at University of Kentucky. Her practice site is at the Neurology Clinic at the VA Medical Center in Lexington, Kentucky. She is a board-certified pharmacotherapy specialist as well as a certified geriatric pharmacist. She is also the chair-elect for the Academy of Pharmaceutical Science, Research and Science of the American Pharmaceutical Association. She has been a faculty member of the ACCP Updates in Therapeutics review course since 2003, and I'd like to invite her at this time.
Welcome. You're on day 2, right? This is good because I'm usually a day 3 kind of girl, so you look a lot more awake than normal. So we're getting ready to embark on our whirlwind tour of neurology, so buckle in and we'll move right along. Let's start with patient case 1. If you've got your case or your prep guide book, that starts on volume 1, page 208. So TM is an 18-year-old new patient in the pharmacy where you work. He presents a prescription for carbamazepine 100 milligrams BID with instructions to increase to 200 TID. Currently, he doesn't take any medications, does not have any drug allergies. During your counseling session, he tells you he needs to have a blood draw in 3 weeks. So get those flashcard things ready. Which common potential adverse effect of carbamazepine is best assessed through a blood draw? Is it leukopenia? That'd be blue. Renal failure? Red. Green is congestive heart failure. Or D, yellow is hypercalcemia. And I'm seeing a sea of blue. Very good. Good warm-up question, right? Leukopenia. So just to review the carbamazepine adverse effects, and now we're on page, I'm assuming you all have seen these before, we're on page down at the bottom 193 if you want to flip back and forth. Okay. So the adverse effects that we're mainly concerned about with carbamazepine include rash, the syndrome of inappropriate antidiuretic hormone release, and then a bunch of blood dyscrasias, including aplastic anemia, thrombocytopenia, anemia, and leukopenia. One thing to note about the leukopenia is almost everyone who starts on carbamazepine will have a little dip in their white cell count. Okay, as long as it's not very low, it's fine, you can just keep going. But you'll almost always see a little bit of a dip there. It's only when it's really low that you need to actually take action. So he comes back. Now he has a new prescription for lamotrigine 25 milligrams with instructions to take 1 tablet daily for 2 weeks. Then 1 twice a day for 2 weeks, then 2 twice a day for 2 weeks, then 3 twice a day after that. And he says, well, I'm not going to take the carbamazepine anymore because I developed a rash a couple of days ago. So what's your best response? Is it A, the rash is likely caused by carbamazepine because the carbamazepine rash often has delayed development? Is it B, it's unlikely carbamazepine because that rash usually presents after the first dose? Is it C, it's unlikely carbamazepine because that's probably associated with carbamazepine-induced liver failure? Or is it unlikely carbamazepine because that's probably associated with carbamazepine-induced renal failure? Okay, so I'm seeing a lot of blue, and indeed that's correct. When we look at dermatological adverse effects in general with the anti-epileptics, they tend to occur after a bit of a delay. It can be 2 weeks to 2 months. Okay, so quite a bit of a delay compared to what you might think of for like an antibiotic or something. And we can go the whole gamut from a fairly mild rash to Stevens-Johnson syndrome, which of course is quite serious, to anticonvulsant hypersensitivity syndrome, which includes organ dysfunction and things like that. So you've got the whole gamut there. And then there are a couple of new pharmacogenomic testing recommendations that have just recently come out in the last couple of years. The first one is actually a recommendation is now in the package insert for carbamazepine. And the recommendation is to test for HLA B star 1502 in patients that are of Southeast Asian descent. And they have about a 10-time increased risk of rash compared to the rest of the world's population. So that's an actual recommendation to do that testing in those patients. Now, of course, we have a lot of different choices now for anticonvulsants, so most people are just choosing a different agent for those folks. But if you need to use carbamazepine, that would be the recommendation. There's also a newer finding about HLA A*3101, and there's no recommendations about this one yet. But in that particular allele, which is more prevalent in Caucasians, they're also at an increased risk for rash. So we may see a recommendation on that in the next year or two. Okay, same guy wants to know why it's necessary to increase the dose of lamotrigine so slowly. What's your best reply? It causes dose-related psychomotor slowing. It causes dose-related renal stones. It causes dose-related paresthesias. Or it causes dose-related rash. Okay, you all are on top of the game. Dose-related rash. Now, the dose-related rash associated with lamotrigine is a little unique because it is related to dose as opposed to being just idiosyncratic. So that's why it's very, very important to do a slow up titration when you start the drug. And particularly, this has been a problem in children because for a long time there wasn't an appropriate dosage form for them. But now there are smaller strength tablets, and it's fairly easy to do that. But it is very, very important to do that. The other thing you have to watch here is because out of all of our antiepileptics, valproic acid is really the only inhibitor. When you give it with lamotrigine, it increases the incidence of rash, and you need to go even slower with your titration. Okay, so very slow. You start it every other day in that case. And the rash, again, may be fairly mild to very serious in nature. Okay. Moving on to case 4. JG, the 34-year-old patient, maintained on carbamazepine extended release 400 milligrams twice a day for the past 2 years. She had no seizures for the past 4 years, and she presents to the emergency department in status epilepticus. What drug should we use first? Diazepam, lorazepam, phenytoin, or phenobarbital? A little bit of a mixed response here, but some of you are quickly succumbing to peer pressure, right? Okay. So the correct answer here is lorazepam. So let's talk a little bit about status epilepticus and what we do there. Recently, the terminology has changed just a little bit with the most recent guidelines. So the first drug we use now is called an emergent medicine. And in that case, what we want to do there is stop the seizures immediately. Okay, that's the purpose of your emergent medicine. Almost always what we're talking about is a benzodiazepine. Okay, so that should be your emergent medicine. Then you want to follow up immediately with an urgent medicine. Okay, so these would be the longer-acting medicines, is what they used to be termed. The point of them is not so much to stop the seizure right away, although it would stop it, it just takes a little longer, but to prevent the recurrence of seizures when the emergent medicine wears off. Okay? So in this case, we're talking about usually phenytoin or fosphenytoin. Also included in the guidelines are phenobarbital, but I feel like more and more we're seeing a lot more people going with valproic acid, levetiracetam, and some of those drugs as opposed to going straight to phenobarbital as the second drug. Okay. So I like to think of this, we have to do them both, right? It's sort of like a 1-2 punch, right? We do a little jab, and then we do a big uppercut, right? And that takes care of it. We get a knockout. Okay. All right. Another thing to keep in mind with status epilepticus, in general, all the medicines that we use for it should be parenteral. Okay, does that make sense? It's an emergency. We give IV drugs. Okay. The reason I bring that out is, because like if carbamazepine is a choice, you wouldn't use it because it doesn't have an IV dosage form. Does that make sense? Okay. Also, we don't want to use neuromuscular blockers as a treatment for status epilepticus. It will stop the convulsive response, okay, but it doesn't do anything to what's going on in the brain. Now, where we might use it is if you need to intubate a patient, of course, you would use a neuromuscular blocker. But we don't use it as a treatment for status epilepticus. Okay. So now, back to the nature of this question. Why is lorazepam the drug of first choice for seizure therapy? Because on that particular question, diazepam was also a possible answer. Well, what we know is lorazepam is less lipophilic than diazepam. And so you're thinking to yourself, now wait a minute, why is that a good thing? Because don't we want it to be more lipophilic, get into the brain faster? And it's true, diazepam does get into the brain faster, but it's not a lot faster. Okay, it's a difference in seconds to a minute. So what we're saying is that it's more important, though, to get into the brain slightly slower but stay there longer, because diazepam runs off to the rest of your body wherever you have fat. And frankly, your butt really doesn't need it. Okay, so it's better to have the lorazepam getting into the brain, staying there, instead of the diazepam, which gets in a little bit quicker but then redistributes. Okay, moving on to case 5. SR, 37-year-old patient, began taking phenytoin, 100 milligrams, 3 capsules, QHS, 6 months ago. He's experienced several seizures since that time. The most recent was this last week. At that time, they did a phenytoin serum concentration and found 8 micrograms per milliliter. The treating physician increased his dose to 100 milligrams, 3 capsules, twice a day. So, what do you expect his serum concentration will do? Will it be 10 micrograms per mil, 14 micrograms per mil, 16 micrograms per mil, or 20 micrograms per mil? Okay. And I agree, you don't really even have to do the kinetics here, right? We know it's going to be high, 20. Why is that? Okay, so prepare yourselves. I know some of you are ready to have PTSD from like a kinetics exposure here. Okay, so if you remember, there's nonlinear or Michaelis-Menten kinetics with phenytoin. So basically what we say is doubling the dose. It's not linear. You're going to more than double the concentration. Okay. One more thing, just a reminder about phenytoin pharmacokinetics, very highly bound. So if you have issues with albumin being low for whatever reason, you're going to have a higher free concentration that you need to consider. Okay. SS, a 22-year-old woman who has always had episodes of zoning out. Recently, she had one of these while she was driving. She had a non-injury accident, but it did prompt a visit to the neurologist. She's given a diagnosis of absence seizures. So, which drug is best to treat this type of epilepsy? Is it phenytoin, tiagabine, carbamazepine, and ethosuximide? Did you all study these things at home before you came? You all are doing really well. Okay, ethosuximide, good. So in general, and this is not a completely true statement, but if you remember the drugs that you use for absence seizures, everything else is for the other stuff. Okay, so the ones to really, like, when you look at them, you're like, I have 20-some drugs here to remember. Just remember the ones for absence, okay, and you'll do better. So first line for absence seizures, ethosuximide. Biggest problem with ethosuximide is it doesn't treat any other kind of seizure. Okay, so if you have someone with a mixed seizure type, you would definitely use valproic acid, or possibility of lamotrigine, clonazepam, and there are a couple of others that can be used there. Okay, JB, 25-year-old man, history of seizure disorders. He's been treated with phenytoin, 200 milligrams twice a day for 6 months, and his current concentration is 6.3 micrograms per mil. His neurologist decides to increase his phenytoin dose to 300 2 times a day. Which adverse effect is he most likely to experience related to the dose increase? Is it drowsiness, acne, gingival hyperplasia, or rash? And the rest of you are like, wow, I'm so glad that wasn't another kinetics question, right? Okay, drowsiness, correct answer, yes. So when we think about adverse effects to phenytoin, we have dose-related adverse effects and then we have the non-dose-related adverse effects. Dose-related are generally things like nystagmus, ataxia, drowsiness, and cognitive impairment. Whereas the non-dose-related things that you see include gingival hyperplasia, right? Very common question on exams because it's kind of a unique side effect. Hirsutism, acne, rash, hepatotoxicity, and coarsening of facial features. So just as an aside here, we hardly ever give phenytoin to adolescent girls. Can anyone tell why, looking at this list of non-dose related adverse effects? Okay, no adolescent girl likes the idea of having to shave, right? Just right out. Okay. Next case, case 8. MG is a 15-year-old male adolescent, diagnosis of juvenile myoclonic epilepsy. He's been prescribed sodium divalproate. What do we need to talk to him about? Is it oligohydrosis, renal stones, alopecia, or word-finding difficulties? Okay. The right answer is alopecia. So when we look at adverse effects of valproic acid, we need to think about very serious ones like hepatotoxicity and pancreatitis, but also some other things that can happen include nausea and vomiting, which is why we have a coated formulation, weight gain, interference with platelet aggregation, so sometimes we see problems with bleeding, and then alopecia. And sometimes when the hair grows back, it grows back curly if it was straight before. It's called the perming effect of valproic acid. Patient case 9. GZ is a 26-year-old woman, presents with a 6-month history of spells. The spells are all the same. They all start with the feeling in the abdomen. It's difficult for her to describe what it feels like, but then it rises toward her head, and then she loses awareness. After a neurologic workup, she's given a diagnosis of focal seizures evolving to a bilateral convulsive seizure. The neurologist is considering either carbamazepine or oxcarbazepine. So, if you're comparing these two, which one is most accurate? Is it oxcarbazepine causes more liver enzyme induction than carbamazepine? Oxcarbazepine does not cause rash. Oxcarbazepine does not cause hyponatremia. Or oxcarbazepine does not form an epoxide metabolite in its or intermediate in its metabolism. So I'm curious, are you all doing this well on like cardiology too? Yeah? You should just skip and take the class or take the test tomorrow, okay? So it's true that it does not cause an intermediate with an epoxide. It is an enzyme inducer, however, but it is not an auto-inducer. So that is kind of an important difference between the two drugs. Okay. And I get a lot from, especially physicians, who'll tell me it's a prodrug for carbamazepine or it's a metabolite of carbamazepine. It's not either. It's just structurally similar. Okay. Hyponatremia is more common than with carbamazepine, and blood dyscrasias are a little less common. So those are some other differences between the two. So when we see this patient back 6 months later for follow-up, she says, "Oh, I'm 6 weeks pregnant. She's had no seizures since she started drug therapy." So what should we do? Immediately stop her anti-epileptic drug, immediately discontinue the drug and give folic acid, continue her anti-epileptic drug, or change her anti-epileptic drug to phenobarbital. This one I usually get a little controversy. You all seem very united on it, though. I would continue her anti-epileptic drug. Okay, so when we look, there are some guidelines for women of childbearing potential. In general, we should choose the best medication for the person's seizure type. Okay, I know that sounds sort of like, yeah, okay, but there are a number of people that will say, oh, well, in any woman with childbearing potential, we should use a B category drug. And for years, ethosuximide was the only one. Well, obviously, if the patient doesn't have absence seizures, ethosuximide is going to be a really poor choice, right? So they need to have the right drug for their seizure type. If possible, monotherapy is preferred, and that's true of all patients, okay, a little more maybe in women with childbearing potential. We need to talk about a potential decrease in oral contraceptive efficacy. Now, and this is only with the enzyme-inducing drugs, and you can use a higher dose of the ethinyl estradiol or I never can say that one, the other drug there. Okay, so one of those two at a higher dose is possible. However, I would like to also point out that when we're talking about a decrease in efficacy, it's not like by 50% or something, okay? It's just a few percentage. So with best use for an oral contraceptive, you're talking about like 95 to 98% efficacy to start with. So reducing that by a few percent is not a whole lot. Okay, we still want to use precautions. We still want to recommend the higher doses, not many pills or anything like that, but it's still fairly effective. And then in all women of childbearing potential, the recommendation is to go on and use the folic acid supplementation of at least 0.4 milligrams per day. Some clinicians go on and do 1 milligram a day, so using like a prenatal multivitamin in women with childbearing potential even when they're not pregnant. So that's another possibility. And then during and after pregnancy, we would hope that all the medications are optimized before conception. That is our ideal scenario. And if a woman has been seizure-free for a number of years, wants to stop therapy, something like that, then we want to do any withdrawals at least 6 months before conception. Now, I read this and I just kind of laugh about it because in the last 18 years, I've had exactly 2 patients come in before they were pregnant or call before they were pregnant and say, I'm thinking about getting pregnant, what should I do about my medicine? The much more common scenario is, I'm 3 months pregnant, I don't know what to do. I need to get off these medicines. Okay, so you need to treat most women as though it's a potential of pregnancy, even if they're not stating they're actively trying to become pregnant. We do want to avoid valproic acid if at all possible. The rate of malformations is higher, definitely. There's been some recent pregnancy database information on that tells us that the rate of malformations is definitely higher. And one of the big malformations, very serious malformation that can happen with valproic acid is spina bifida. Okay, so not closing the neural tube. And, that requires, at the very least, a surgery usually immediately after birth. And sometimes the babies are stillborn or miscarried. So a very, very serious thing with valproic acid there. Again, monotherapy, so avoiding polytherapy if possible. In general, we don't tell women they should not breastfeed while they're on these drugs. They're mostly too large to really get into the breast milk. The exception there would be something like a benzodiazepine, which does get into the breast milk, but that's only an issue when you start tapering off breastfeeding. So that's something you'd want to make the pediatrician aware of. We don't recommend not to breastfeed. It's just you have to be aware. And then monitoring serum concentrations. Ideally, you would have concentrations before conception, at the beginning of each trimester, sometime during the last month of pregnancy, and during the first 8 weeks postpartum, because you may need to readjust after delivery. And those are recommendations for all of the medicines you see here: lamotrigine, carbamazepine, phenytoin, levetiracetam, and oxcarbazepine. So a little bit more expanded than what we think of normally as our therapeutically monitored drugs. Okay, next case, number 11. We're going to switch gears now, stroke. So flip on over to page 214. LR is a 78-year-old man who presents to the ER for symptoms of right-sided paralysis. He states that these symptoms began about 5 hours ago, and they've not really improved since that time. He also has hypertension, BPH, diabetes, erectile dysfunction, and osteoarthritis. So what's the most accurate assessment of his risk factors? Is it A, erectile dysfunction, age, and osteoarthritis? B, sex, diabetes mellitus, osteoarthritis? C, BPH, diabetes, age, and sex? Or D, age, diabetes, sex, and hypertension? Just waiting for me to read out that D. Right, okay. So when we look at stroke risk factors, we have things that are non-modifiable, somewhat modifiable, and then modifiable. And the modifiable list is growing, actually. So non-modifiable, those are things obviously we can't change. So believe me, if I could change age, I would not still be working, okay? Race, can't change. Sex you can change. To the best of my knowledge, though, you would retain your biological sex there, okay? Low birth weight, obviously can't do anything about that after the fact, and family history. So those are all the non-modifiable things. Diabetes falls into the somewhat modifiable category. It definitely is a huge risk factor for stroke. But it's not clear how much that having really, really good control of diabetes improves your large vessel disease issues. Okay? So that's why it's in the somewhat modifiable thing. Definitely we still advocate for control there, obviously, for multiple reasons, but but it's not absolutely certain that it's hugely modifiable for stroke. Modifiable, though, here's where we spend our time, right? And you'll notice all these things that have drugs associated with them or are a good place for pharmacists to intervene. So hypertension, smoking, use of hormones, AFib, about 5% per year risk. That's probably the number one risk. Coronary artery disease, carotid stenosis, dyslipidemia, obesity, physical inactivity, sickle cell, SLOD2, peripheral artery disease, pregnancy, patent form and ovale, depression. Okay, so those are some things that we can change. Then we have this other list now. These are things that we think are related, but they're not as well characterized as the things that we know are definitely modifiable. So either we don't know how much they contribute to risk, or we don't know if modification of them changes the risk. Those include alcohol abuse, hyperhomocystinemia, drug abuse, hypercoagulability, periodontal disease, acute systemic inflammation and infections, and that's, of course, in the immediate period thereafter, sleep disordered breathing, apnea, metabolic syndrome, and then migraine with aura. Okay, so back to the patient. Is he a candidate for tissue plasminogen activator for the treatment of his stroke? Yes. No, he's too old. No, his stroke symptoms began too long ago. Or no, his diabetes is a contraindication. Okay, good job. His symptoms did begin too long ago in this case. So let's review the criteria for use for TPA. I think it helps when you think about these to really just think about what are some big risks for bleeding, because that's what most of these are about. So the other thing to keep in mind is there's slightly different criteria for people within 3 hours and then those who are longer than 3 hours. So the initial studies done with TPA looked at the first 3 hours, and then there have been more recent studies that expanded that time window, but they have additional criteria. So let's start with the 3 hours. And when we talk about 3 hours, that needs to be the last time someone saw you normal, or you know you were normal. Okay, so if you were normal when you went to bed and you woke up at 6 a.m. with stroke symptoms, you have to count that as 6 hours. Does that make sense? Okay, sometimes I see people and they're like, well, I'm going to average it out. I don't know where that comes from, but that's not how you do it. 3-month outcome is significantly improved when we use the drug. There is an increase in hemorrhage when we use TPA, for sure. But it's still improved morbidity, mortality with the use. And the dose, I'm pointing it out just because it is a little bit different than it is for MI. The dose is 0.9 milligrams per kilogram with a maximum of 90. So there's a weight-based maximum with 10% as a bolus and the rest is given over an hour. Okay, so the exclusion criteria. For the 3 hours, if the patient has bleeding already in their head, we should not give any TPA. Right? Good idea. Okay. If they have any other spouting blood anywhere, we should not give TPA. If they've had recent surgery, head trauma, or stroke, now recent, you're like, what is that? Usually for this, it's counted within 2 months. There's not a specific thing. It just says recent in the guidelines. But usually 2 months is the indication there. If the blood pressure is high, and this is pretty darn high, right? 185/110. And we can't lower it within the time frame and keep it stable. So like in our emergency department, we have the TPA packaged with drugs to lower blood pressure. That way they're there and ready. So if you can get it lower and it can stabilize, you can give the TPA, but it needs to still be within the time frame. If the patient has a seizure at stroke onset, which may indicate some blood we haven't seen, may indicate a larger stroke, it also could mask some post-ictal things, could mimic stroke symptoms, so we don't want to treat a seizure with TPA in general. If the patient has a tumor in their head, an AV malformation, or an aneurysm, those are all contraindications. And then if the patient's on active treatment with warfarin, meaning that their INR is above 1, they're on active treatment with heparin with an elevated PTT, or if they have thrombocytopenia, we don't want to give something that's going to cause bleeding. Okay, so that was the 3-hour criteria. If we can get somebody in between 3 and 4.5 hours, we can still give the TPA. We have all those former criteria plus these. They should not be taking any oral anticoagulant, okay, regardless of their INR. They shouldn't have a baseline NIH stroke scale score greater than 25. Okay. They shouldn't have a previous stroke and diabetes. And they shouldn't be older than 80. So those are the extra special criteria for the longer time frame. Notice nowhere on any of these does it say they can't be on aspirin. Okay, so that's a common question I get. What if they're on aspirin, not warfarin? As far as we know, that's fine. Okay, patient, same guy, previously taking no medicines at home. What would we use for secondary stroke prevention? Sildenafil, Celecoxib, Vicks, aspirin, or warfarin? Okay, great. Most of you chose aspirin, and that's the correct answer. When we look at the guidelines, these are the most recent CHEST guidelines, what do we do to prevent the next stroke? Well, first we want to look at all of those modifiable risk factors and see what we can change. So make sure you're maximizing any therapy there. Carotid endarterectomies may be helpful if you have someone with significant blockage in the carotid arteries. And then you can use any one of these medicines. So aspirin, sustained release dipyridamol, ticlopidine, clopidogrel, cilostazol, or warfarin. I will say that probably of these, the 3 that are most commonly used are aspirin, sustained release dipyridamol, or clopidogrel. Okay, one of those 3 are probably the most commonly used, but they're all recommended in the guidelines. Okay, you're the pharmacist at a community pharmacy. You receive a call from MW. This is a 64-year-old man recently given a diagnosis of AFib. He's concerned about his risk for having stroke because he's got this friend who has AFib. And his friend said, well, what dose of warfarin are you taking? And now he's concerned because he doesn't have warfarin. And he wants to know if he should be on it. He has no other medical conditions, and the only medicine that he's taking is altenolol, 50 milligrams a day, for ventricular rate control. So we say, you should really talk this over with your physician, but A, you need warfarin to prevent a stroke. B, you don't need warfarin. You should take aspirin and clopidogrel. C, you don't need any drug therapy at this time. Or D, because you have AFib, nothing can help you. Okay, I'm glad none of you are just saying you're doomed. That's good. Okay, so correct. You don't need drug therapy at this time. And this changes quite a bit. This is a pretty big change in the most recent CHEST guidelines. But they're still recommending use of the CHADS-2 score. Remember, CHAD stands for congestive heart failure is the C, the H is hypertension, age is A, above 75, diabetes is D, and prior stroke or TIA. The reason the 2 is on there because if you have those, you get 2 points. So you add up all the points, and if the total is 0, you can either do aspirin or no therapy. So that's a little bit of a change from previous guidelines. And if the total is anything above that, then you would give an oral anticoagulant or aspirin and clopidogrel. And also new in the guidelines is dabigatran is recommended over warfarin in patients that don't have a contraindication, obviously. Okay, so if we look at our person here, our case, he has a total of 0 because he's not had any of those things before. And so he could either be on no therapy or aspirin. Since I didn't give you aspirin as a choice, no therapy. Patient case 15, LS, is a 72-year-old woman with a medical history of hypertension, type 2 diabetes, renal failure, AFib. She presents to the anticoagulation clinic for her initial visit. And this one is an easy one, right? What's her target INR? 1.5, 2, 2.5, or 3? I just thought you'd want a break here in the middle, right? Okay, so 2.5 is right. Good job. Number 16, Here's a sneaky way to get statistics in here. You work as a clinical pharmacist in a small hospital. Several of the physicians with whom you work want to use aspirin and clopidogrel together after a stroke to prevent the next stroke, similar to what they're doing for MI. You access the match study, and here's what you get for results. Okay, so let's walk through the table because it's a little much maybe. The primary outcome was a composite outcome, and that's the primary outcome on that top line. And then there were several secondary outcomes, MI, ischemic stroke, and all-cause mortality. And those are those three at the bottom. All right. How are you going to interpret this? Aspirin plus clopidogrel is more effective than placebo plus clopidogrel, only for the primary outcome. And just to pop back there, I'm sorry, I didn't point out on top, aspirin, clopidogrel is the first column, and placebo was compared with clopidogrel still, though. So the only difference was plus or minus aspirin. Okay. All right, so aspirin plus clopidogrel is more effective than placebo plus clopidogrel, only for the primary outcome. B, aspirin plus clopidogrel is more effective than placebo plus clopidogrel for all of the secondary outcomes. C, aspirin plus clopidogrel is more effective than placebo plus clopidogrel for prevention of MI. Or D, aspirin plus clopidogrel is no more effective than placebo plus clopidogrel for any of the listed outcomes. Since it took me so long to read, you all got caught up there. Okay, so the right answer is D. And let's just remind ourselves about relative risk reduction. A relative risk reduction of 1 indicates that there's no difference. So our confidence interval, which tells us that we are 95% confident that the answer is within it, also can't contain 1. Okay, so very good. Switching gears, let's go to Parkinson's. That's page 219. All right. LS is taking levodopa, carbidopa, 25-100, 4 times a day, and trihexyphenidyl, 2 milligrams, 3 times a day for his Parkinson's disease. His wife reports he's often confused, and he experiences constipation and has trouble talking because he has a dry mouth. What change is best to resolve those symptoms? A, increase the carbidopa-levodopa. B, increase trihexyphenidyl. C, decrease carbidopa-levodopa. Or D, decrease trihexyphenidyl. Hooray, yes, decrease trihexyphenidyl. So when we think about Parkinson's disease treatment, we generally can take our drugs and divide them into 2 categories. Almost everything increases dopamine, or is called dopaminergic. And those common adverse effects because of an increase in dopamine, so the things that they have in common, include nausea and vomiting, orthostasis, and hallucinations or vivid dreams. So those are really common things that you're going to see to all of the dopamine types of drugs. On the other hand, we have the anticholinergic things, and we should all be able to recite this like a mantra, right? Dry mouth, urinary retention, dry eyes, constipation, and confusion. I feel like I can. Okay. All right, so 6 months later, he comes back. He's concerned now that his dose is wearing off before his next dose is due. What will you do? Increase the dose of carbidopa-levodopa, decrease the dose of carbidopa-levodopa, increase the dosing interval, or decrease the dosing interval. Okay. Looks like everyone's choosing decreasing the dosing interval. I like to point out that decreasing the dosing interval means what? That we give the doses more often or less often? Good. Don't get confused about that. It is more often, right? All right, so when we look at some of the adverse effects of carbidopa-levodopa, 2 of the ones that you probably heard about in pharmacy school include wearing off and on-off. So let's talk about what the difference is here. So wearing off is exactly what it sounds like. It's before the end of the dosing interval. It's time to take more medicine because your medicine is just worn off and your symptoms have come back. So if you remember that one, on-off is the other one. And the reason it's called on-off is because it's unpredictable. It's sort of like turning off and on a light switch. Suddenly symptoms come back, and there's not a clear relationship to the dosing interval. So it could be at the beginning, the end, maybe the dose just has no effect, any of that. Our strategies for them are a bit different. Wearing off is fairly easy to treat. Okay. The obvious thing is to give the doses more frequently. You can also use a controlled release formulation. You can add a COMT inhibitor, or you can add a dopamine agonist, and all of those things work fairly well. On-off is much more difficult to treat and much more frustrating for a patient because it's completely unpredictable. So things we can do, we can add a COMT inhibitor, we can add an MAO-B inhibitor like selegiline or rasagiline, we can add a dopamine agonist, or we can use apomorphine. We can also try redistributing the dietary protein. The reason that may help, and usually I don't see this help much unless it's fairly advanced Parkinson's disease, but all the L-amino acids in bacon and eggs and whatever else you have as your protein, steak, compete with the L-DOPA for absorption in the gut. Because of that, sometimes if you have your dietary protein apart from that, you won't have that competition and you'll get more absorption, so sometimes that does help. Generally, I have patients ask me a lot of questions about it, and then they try it and they discover there's not that much difference unless they have fairly advanced disease. But sometimes you'll probably be asked questions about that, and sometimes it does help. Okay, our next case, patient 19. He's a 57-year-old man, an 8-year history of Parkinson's. His current drugs include carbidopa-levodopa, 5,200 milligrams orally, 4 times a day, entacapone 200 milligrams orally 4 times a day, and amantadine 100 milligrams orally 3 times a day. He presents to the clinic with a reddish-blue discoloration in his lower arms and legs, which, if any of his drugs is the most likely cause of this condition, is it A, carbidopa-levodopa, B, entacapone, C, amantadine, or none? This is probably venous stasis. And the right answer is C. Okay? So this is called livedo reticularis. Not only fun to say, but also it has been on every standardized exam I have ever taken. Okay, so it was on my board exams, it was on my BCPS board exams, and it was on my CGP board exams. Every one. So I feel like I'm giving you a little gift today. Okay? So livedo reticularis. Much like aurora borealis, it is a fun thing to say. So it is a reddish-blue discoloration, usually in the lower extremities, but also could be in the upper. Not harmful. If you stop the drug, it almost always goes away. Sometimes accompanied by a little edema. It does make them not shorts candidates often, and sometimes patients will report problems with it. Okay. But just to review some of our other special adverse effects with the anti-Parkinson's agents that we haven't already talked about. The dopamine agonist with the ergot-derived agonist, which include bromocriptine and pergolide, they've been rarely associated with fibrosis, including cardiac fibrosis, pleuropulmonary, and retroperitoneal. And in fact, pergolide was also associated with valvular heart damage, and that is why it is no longer available. Okay. In general, that's not been a problem with any of the other dopamine agonists, but it is something certainly that all of the new agents are being examined for. As we said, amantadine and livedo reticularis. The COMT inhibitors include diarrhea, and that diarrhea can be fairly delayed in onset, somewhere from 2 to 4 weeks. So it's not necessarily like they have their first or second dose and then develop diarrhea. And then urine discoloration is seen with entacapone. And for me, urine discoloration, I would think some really bizarre color, but it makes your urine orangish to deep yellow, which to me is sort of in the normal spectrum of urine color. But if that's a departure, you might need to tell patients about it. Okay, another Parkinson's case, number 20. LL is a 47-year-old man with Parkinson's disease. He takes carbidopa-levodopa, 50-200, 4 times a day. Recently noticed an involuntary twitching movement of his left foot. He's been diagnosed now with the dyskinesia. So should we add ropinirole, add selegiline, increase carbidopa-levodopa, or decrease carbidopa-levodopa? Okay, right. In this case, we want to decrease the carbidopa-levodopa, the answer D. So one of the adverse effects, and this can happen actually with any of the dopaminergic drugs, but it's probably most commonly associated with carbidopa, levodopa, is dyskinesias. So these are unusual movements, sort of dance-like or choreoform movements that occur when the concentration of dopamine gets too high, basically. So the basic answer there is to start decreasing dopaminergics. The biggest problem with that is people don't usually get on those doses just randomly, right? They increase slowly over time because they needed more. Or their disease has gotten worse and that sort of thing. So you may have sort of mixed success with decreasing dopaminergic agents because of the disease state. The other thing you can do is add amantadine, and sometimes that will help. So there's kind of two places where we use amantadine, either fairly early in Parkinson's disease to treat the Parkinson's, or later if someone develops dyskinesias. Patient case 21. You all are hanging in there pretty well. CA is a 57-year-old white man just retired from the New York City Fire Department. He's been experiencing tremors in his right hand that have become progressively worse for the past 6 months. He has difficulty walking, he also has backaches, and he no longer plays golf. In addition, he's losing his sense of taste. He's being diagnosed today with Parkinson's disease. So what would you do? Would you give him trihexyphenidyl, entacapone, apomorphine, or ropinirole? Okay, so you all are choosing ropinirole, and that's what I would choose for him too. So let's think about why we would do this. You could use an anticholinergic, but in general, the main symptom that they treat is tremor. So the man has a little bit more than just tremor. He's got some slow movements and things like that. So that's not going to address those problems. So that's why I wouldn't choose the anticholinergic by itself. COMT inhibitors, the ones that we currently have, don't cross the blood-brain barrier. So because of that, they have to be given with carbidopa, levodopa. If you see them by themselves, that's an error. So we can't really use the COMT inhibitor and entacapone there. And apomorphine is a dopamine agonist, but it's a parenteral formulation that's really only used for severe on-off symptoms. So we wouldn't use that in this case for a maintenance dose. Okay, switching gears once again, we're on to the world of headache. We have MR, a 34-year-old pharmacist, developed throbbing right-sided headache, experiencing nausea, sonophobia, and photophobia with the headaches, but no aura. She usually has headaches twice a month. She's hypertensive, she's morbidly obese, she takes ethinyl estradiol progestin combination oral contraceptive, and hydrochlorothiazide 25 milligrams a day. She has a diagnosis now of migraine headache. What medication is the best for prophylaxis of her headache? Is it propranolol, valproic acid, amitriptyline, or lithium? Okay, getting a lot of A, and that was what I would choose too, propranolol. So let's have a small discussion about when do we use prophylaxis. There are guidelines, and I've got them on the slide for you here. If you have somebody who has recurrent headaches that interfere with their daily routine, they would be a candidate. If you have someone with frequent migraines, and that's usually considered more than twice a month, so again, one of those nebulous words like frequent, in this case twice a month. If they can't use any acute therapy, maybe they have contraindications to one of the triptans, something like that, if they can't use acute therapy for some reason, then prophylaxis becomes even more important. And for me, this is kind of the kicker, if the patient prefers it. So if I tell someone, well, to prevent these headaches, you can take a medicine every day, and they go, okay, sign me up, then I think they're a pretty good candidate. If I say you can take a medicine every day, and they're like, I don't know if I want to do that, then they're probably not a candidate, right? If they're having problems with affording the acute medicines, if they have significant adverse effects with the acute therapies, or if they have some kind of uncommon migraine presentation. And sometimes we'll see this where people will have like a one-sided paralysis or something, so you have people being worked up in the ER for stroke who are women in their 20s. Okay, so not impossible for a woman in her 20s to have stroke, but not very common, right? So that's the kind of person we want to make sure that we go on and prophylax for headaches so that we don't have those complications. Okay, so other principles about prophylactic agents, of course, you use the lowest effective dose. You want to give an adequate trial, which is usually 2 to 3 months. And, this can be sort of difficult to convince somebody to stay on something if you're doing a low dose and 3 months later, increase that low dose to a little bit higher. But you want to make sure they have an adequate trial before you say it was a failure. And then probably, for me, this is the most key part of it, is that you want to think about other disease states, because otherwise you can use any of these agents. But is there anything else about the patient that either directs you toward one therapy or away from another? So for prophylaxis, there's a big list in your book, but to summarize, frovatriptan has been used, but it's really only for menstrually associated migraines, and you would only use it for a short period of time. Personally, I don't see how you would afford it for any longer than a short period of time, to take every day. Metoprolol is often used. Obviously, that's a good choice if you have someone who has another indication for metoprolol. Same with propranolol, right? Hypertension or some other indication. Could be a bad choice, right? If you have someone that has reactive airway disease or diabetes, you might avoid it. This is a new one in the newest guidelines, Petasites? It's Butterbur. Okay, so that is a natural product that actually has undergone some clinical trials and shown efficacy for prophylaxis. Timolol, another beta blocker, valproic acid, and then topiramate are generally first-line agents. And then there's a table in your book on acute treatments as well. Okay, looking at our next headache case, SR is a 54-year-old female homemaker with squeezing band-like headaches that occur 3 or 4 times a week. She rates the pain of these headaches as 7 of 10 and finds acetaminophen, aspirin, ibuprofen, naproxen, ketoprofen, and piroxicam only partially effective. She wishes to take a prophylactic medicine, and she's been diagnosed with tension headaches. So what's best for prophylaxis? Is it propranolol, valproate, amitriptyline, or lithium? Same choices. Okay, seeing a lot of amitriptyline, and I would agree with you here. For tension headache treatment, the list is not nearly as long. The things that have been shown to be effective for prophylaxis are tricyclics or botulinum toxin. For acute treatment in general, we want to think about acetaminophen or NSAIDs. This particular woman, that's been problematic because she's kind of worked her way through. So prophylaxis is probably a very good choice for her. Next headache patient, DS, is a 49-year-old male computer programmer. He describes lancinating right eye pain and tearing several times a day for 2 to 3 days in a row. Then he'll have no episodes for several weeks, and then he'll have a recurrence of the same pattern. In the office, he gets oxygen by nasal cannula, and it relieves his episode that he's currently having. So he's given a diagnosis of cluster headaches. Same choices. What's best for prophylaxis? Propranolol, valproate, amitriptyline, or lithium? You guys are all over it. It is lithium. So prophylaxis for cluster headaches, the drugs are a bit different from the others that we've seen. So verapamil, melatonin, a suboccipital injection of betamethasone or lithium. Acute treatment, triptans can work, oxygen by nasal cannula also works, and intranasal lidocaine. The biggest problem with acute treatment of cluster headaches is that often they're over before you really start treating them. So you need to use faster acting dosage forms. So with the triptans, we would usually use either a parenteral formulation, which would be sumatriptan, or the intranasal formulations. So those would be the drugs we would look at there. So particularly in cluster headaches, prophylaxis is pretty key for those because they don't last long enough to really do a lot for acute treatment. And oxygen is hard to carry around with you. So one more headache case, case 25. MK is a 44-year-old woman with right-sided headaches of moderate intensity. They're accompanied by severe nausea and vomiting. Which triptan is best? Is it almatriptan, naratriptan, rizatriptan, or sumatriptan? I can't fool you with anything. You guys are so sharp. So sumatriptan is the right answer. Why sumatriptan? Okay, it's got dosage forms that aren't oral. right? And the others are all oral only. So somebody with severe nausea and vomiting, we'd want to be thinking about non-oral dosage forms. One more sneak statistics question. One of the neurologists that you work with recently read a meta-analysis of migraine treatments. He's most interested in the outcome of sustained relief at 24 hours, but he's confused by the number needed to treat analysis. So he gets you a table and shows it to you. So what you've got here is the combination of ergotamine and caffeine. The number needed to treat is 6.6. Elatriptan, 80 milligrams is 2.8. Rizatriptan, 10 milligrams is 5.6. And then sumatriptan, 50 milligrams is 6.0. So how are you going to interpret this? A, elatriptan 80 is the most effective agent. B, ergotamine plus caffeine is the most effective agent. C, elatriptan has the most adverse effects. Or D, ergotamine plus caffeine has the most adverse effects. Okay. And that's correct. Elatriptan 80 milligrams is the most effective agent. So just a reminder, number needed to treat is a way to say how many patients would we have to treat in order to have one patient who has the benefit. We can do number needed to harm, which is the same thing, except number of patients we would need to treat to have one person have that adverse effect. So you put 1 over the percent improved on active therapy minus the percent approved on placebo, and you get your number needed to treat. So do we want our number needed to treat to be higher or lower? Lower, right? Unless it's an adverse effect, in which case we want it to be higher. Okay, moving on, MS. SF is a 33-year-old African-American woman of Cuban descent who lives in the Miami area. This morning, her right leg became progressively weaker over about 3 hours. She was previously healthy, except she had a broken radius when she was 13 years old and a case of optic neuritis when she was 25 years old. So she's diagnosed with MS. This is an exacerbation. How are we going to treat it? A, interferon beta-1A, B, glatiramer acetate, C, mitoxantrone, or D, methylprednisolone. Okay, correct, methylprednisolone. So when we look at acute relapses, and in general with MS, you want to think about, am I treating a relapse or am I doing something to prevent exacerbations or relapses? In this case, the patient has a relapse or an exacerbation, so we need to do something that will be more immediate. In general, we're looking at steroids with that. So we have kind of 3 choices. We have IV methylprednisolone. Usually you would do 1 gram a day. You can do that all at once. You can divide it up however you want it. And you do that for 3 to 5 days. Other choices, you can do oral prednisone. The dose is high, though. You almost have to always call the pharmacist who's going to fill it and say, yes, it's really high, okay? Because you're talking about 1,250 milligrams a day, every other day for 5 doses. You might want to just go on and give a little H2 antagonist there, too. Okay? And then we have IV ACTH, which is mainly, when we've used that recently, it's been when we haven't been able to get methylprednisolone, but it is a possible agent as well. A lot of times people want to know, should we do a prednisone taper after one of these therapies? There actually is a study that addressed that, and they found there was no difference in recovery time or relapses with or without the taper, so you can do either. Okay, so same patient. What are we going to do to prevent future exacerbations? Interferon beta-1A, interferon beta-1B, glatiramer, or any of those? Okay. The answer is D. You could use any of those. So any of those are perfectly fine first-line agents to help prevent future exacerbations and to help prevent decline and neurological damage. So in general, these agents are called disease-modifying therapies, or DMTs. You'll see them referred to that way. So this patient decides she's going to start on beta-interferon 1B, and she wants to know if there's any way she can prevent or minimize any of those adverse effects. So what do you tell her? Always give the injection at the same time of day. B, lie down for 2 hours after you do the injection. C, rotate your injection site. Or D, use a heating pad on the injection site. Okay, that's what I chose too, rotate the injection sites. So a very common adverse effect with our injectable therapies is injection site reactions. The intramuscular product generally doesn't have nearly as bad of an injection site reaction as the subcutaneous products. But with any of those, some things that you can do to help are to bring the medication to room temperature before you do the injection. You can ice the injection site for 5 to 15 minutes before the injection. And it is very important to rotate the injection sites, and that's because if you do the same place over and over, you can get like a hard subcutaneous knot in that area. So you want to move them among all the injection sites that are possible for the patient. And that's it. So that was our whirlwind tour of neurology. I didn't ask beforehand. I don't see any microphones. Oh, no, there are microphones. So if you guys have questions, feel free to approach the microphone. If you don't want to ask in front of everyone, I'll be happy to stay up here for a bit.
A couple of your female case patients were on oral contraception for headache. The case was about headache, but both patients were on oral contraception. So would you recommend alternative therapy and before you started headache prophylaxis? Or
Okay, so the question is if the patient is on an oral contraceptive, has headaches, is that associated with headaches and not? Generally, it's not been associated with tension headaches. Migraine is usually where you see the association. And sometimes you would modify that, particularly if you can get a good, clear association that, I never had headaches until I started taking an oral contraceptive. A lot of times, of course, in women, you don't see headache onset until puberty, which is a good indication as well. So if you have someone like that, you sure could recommend alternative therapy, an IUD or any other contraceptive method. Sure. And that it depends on how much the patient, I guess, wants to take the oral contraceptive versus something else. Any other questions? All right, it's been a pleasure. I'll be up here if anyone has anything.